Good afternoon, everyone. This is Andy Reese, Director of DDS. Starting out, I just want to let people know that today I have a meeting immediately following this one, and so I am going to be jumping off at 12:55. Um, if there are questions that still require answers, there are folks here who can remain on the line, but I really need to be on time for my next meeting. Um, and as we're talking about scheduling, it occurs to me that 2 weeks from today and the week after that are both Friday holidays. And so after next week, we will then not be meeting again for 3 weeks. So I'd like to share data with people. I'm hoping the data, correct? Someone could just say yes, please.
Yes, and Director Reese.
Okay, thank you, because I have everything for my next meeting on my other screen. So,
And yeah, I'm having a hard time hearing you, so I don't know if others are.
Yes, I'm having a hard time hearing you as well.
Yep.
just since we started talking to everyone else.
You
Yes.
sound good now. It was just like a little period of breaking up, so I would just say
Okay.
continue talking. Yeah.
It was probably my tentativeness while I was sharing to make sure I was sharing the correct screen. So first, as you can see, once again, there's been a jump in the number of people who've tested positive for COVID in the last week. It has gone up by 13 from a week ago. It is now at 310. In the month of December, we've had 14. As you can see, November was worse than any month since May. Comparison, sort of a breakdown between placement type compared to the percentage of people who've contracted COVID as the chart on the right shows total COVID infections by placement type, and the chart on the left is the total number of people this year who have been in those placement types. And so, for example, and the colors changed. I'm sorry, I should have fixed that because previously the colors were the same. But in the last week, we've gotten two new reports, one of an out-of-state placement that's not a waiver placement, so it's listed separately. It's not a residential habilitation or supported living placement. One person who was in ADH placement that we provide supports to. So that changed all of the colors on my pie graph. I should have corrected it. So as you can see, in supported living, we have 137 people who have tested positive. In intermediate care facilities, there have been 103. In natural homes, 29. In residential habilitation, 32. And in host homes, there have been 5. As you can see in the other chart, the vast majority of our folks are either in natural homes or in supported living. So here just updated the kind of COVID infection rate by placement type. Intermediate care facilities, the 103 people constitute a little more than 34% of people who are in intermediate care facilities. And of those 103, there have been, of the 103 who've gotten COVID, 17 have died, which works out to a 17.47% death rate. Although, as I've said, we've had a number of people, especially the longer this goes on. To date, it's 8 people who tested positive for COVID, that seemed to resolve. And then sometime later, they died. And we have still not gotten a final cause of death from OCME. For people who have had either confirmed or presumed COVID deaths, the rate of death for people in intermediate care facilities is about 13.6%. We still do have a pretty low percentage of people who are in natural homes who have tested positive. It's 3.11%. That's 29 people out of a total of about 930. Those people who have tested positive have generally not, I mean, the percentage who've not had good outcomes has been fairly high, with 5 deaths out of those 29 people. 4 of those have been confirmed as COVID-related. In residential habilitation, we've also seen a fairly high COVID infection rate, another congregate setting where a number of people live together. And as we all should know by now, this is a very contagious virus. So the infection rate of COVID in residential habilitation is at 29%. The folks who have died, they've all been confirmed as COVID related, and it is 2 deaths, constituting 6.2%. And then in supported living, 137 people who've contracted COVID, which is about 14.7% of the people in supported living. 8% of those people have died. And to date, we've confirmed almost 6% of those as COVID related, and we're still awaiting the final word from OCME, sorry about that, on some of those. Overall, the COVID infection rate amongst people supported by DDA, there have been 310 people out of about 2,400, which is an infection rate of about 12.9%. The death rate of people who have had COVID and have gone on to die has been about 12.2%. And those that have been confirmed as a death related to COVID, it's been 9%. Type, so far in December, of our COVID infections have been in supported living. I've only got the 4 biggest numbers in this chart. That's why it doesn't equal the total number who in December have contracted. November, as you can see, intermediate care facilities constituted 16 of the people who got COVID, and then supported living was 11, 4 in natural home and residential habilitation. People who have required inpatient treatment, and I'm sorry, I don't think. Oh, yes, I did. 121 people have required inpatient treatment. And as you can see, there were 2 people in December, 8 in November. There are currently 5 people who are still in the hospital. And as I've mentioned, overall, we've had 38 people who have had COVID, who have died. Of those, 2 were confirmed by OCME as not COVID related. Another 8, we are still waiting on a final determination by OCME because those other 8 folks died and recovered from COVID. And so if you look at it that way, what we've got is 28 confirmed or presumed COVID deaths. Saying that because November who died, the hospital had determined the cause of death as COVID. And so we're assuming that the OCME agree with that. I did see that there were questions. Sure.
Andy, you sound muffled.
Any and SL.
Director Reese, you are muffled. I think it's your connection. So I don't know if you just want to maybe turn off your video for a minute and see if that works. I don't know if that's something, an option, but.
In supported living, there have been 11 deaths. And of those, 8 have been confirmed as COVID related. We're still awaiting OCME determination on 3. So it says there's a wobble in my audio. Can people hear me now?
Much better.
Well, we received no questions this week by email. So if people do have questions, please share them in the chat box.
Just as a reminder, please make sure to share your questions with everyone in the chat box instead of to panelists or attendees. Thank you.
So I see there's a question regarding the vaccine distribution in the district. We are working with these. The question says, this morning I saw that DC is getting under 7,000 doses initially. How will that affect people supported by DDS and their staff? As people are aware, I believe we've shared this, and I'm pretty sure we do have DC Health people with us as well who can provide any updated information that I don't have. But the information that we have had, for one, is, you know, the initial recommendation from CDC that in the first group should be people in long-term care facilities, which would be, for us, that would include people in intermediate care facilities, as well as the residential habilitation. Our well, and ideally their staff. And in my conversations with Dr. Nesbitt and in our conversations with DC Health would like to see all of our folks be included in the initial vaccine distribution. But as you can see from that number, that could prove challenging, because we're also talking in terms of highest priority would be other people in congregate settings like nursing homes and other long-term care facilities, as well as healthcare professionals who work in like emergency rooms, ICUs, and those folks. So So we are working with DC Health. We're providing them with all of our numbers so that as they try and make a determination regarding the number of actual vaccines that we have for distribution, and then, how those can be allocated most appropriately. And you can see from our numbers in some respects, when you look at COVID infection rates in ICFs and residential habilitation placements, the risk of contracting COVID in those congregate settings is far higher. So, if there is to be, if it is that people we support or staff that work in different kinds of places are in group 1B as opposed to group 1A, it would be that they have identified, that would be identified based on the risk and looking at other people in the city who also have a need for this vaccine. There's a question, how many people are in committed status? We don't track that because whether a person is committed or not is not really a risk factor. And so that's not something that we track regularly. Do we have a plan to mandate the vaccine for people working with persons served? No, we do not. At this time, and DC Health spoke to this last week, there is work being done. And, on education, this is partly challenging because, you may know that the Pfizer vaccine, all of the research data was just made available this week. So in terms of having the education in order to encourage people to get the vaccine, we're just now getting all the information we need in order to compile that education. And there certainly will be significant public information campaigns and education in the city to encourage people to get vaccinated. But at this time, and there are a number of folks from DC Health who could correct me if I'm wrong, at this time, there is no intent to require the vaccine for anyone. I will say it will definitely be strongly encouraged for everyone. We need to get to a point in this, in the city, in the country, where a substantial enough proportion of people are vaccinated that we do reach that herd immunity in a safe way. And so that's going to require confronting, people's feelings about getting vaccines. And it's going to require a lot of education so that people understand the risks and benefits of the vaccine. But at this time, and I'll pause to see if there's any difference of opinion from DC Health, there is no plan to mandate a vaccine under any circumstance that I'm aware of at this time.
Director Reese, that's correct. Currently, we don't have any plans to mandate vaccines at this time. Thank you. Thanks.
And there's a comment here. I don't think it's a question. The problem is that many staff live in Maryland and Virginia, and that isn't considered in the number of vaccine doses being provided. You are absolutely right. And that doesn't just refer to our staff, that refers to healthcare professionals generally. And it is an issue with how the allocation is determined. But I do know that Mayor Bowser has been working on getting the district's allocation increased. But at this time, we will get the amount that we get. So last week, someone, the idea came up about preparing materials for people supported by DDA. Can we update you on the preparedness? The issue is there's not materials yet for anyone. And so modifying those materials, we have spoken with the people at DC Health that are managing the distribution of the vaccine. And so we will work as quickly as we can with them as they've produced materials to then make sure that those materials are accessible to all of our folks. Unfortunately, like I said, the information you need to really pull those materials together is only just now available. Can IDS people stay in the day program building versus being in the community as before, noting that it's not safe out there and there are so many limitations? Can they participate in activities in the building and have limited community outings? And I'm going to defer to Winslow on that about what's appropriate IDS versus other particular services the person could be doing. Winslow, if you're speaking, okay, there.
So IDS is community-based, and it's to support a person's goal moving towards employment or a interest that is community-based. Programming within a building is day habilitation, so we have no plans of having IDS being conducted in a community-based building.
So I will defer this question to DC Health. There was a question about screening people's temperature at the door in the winter because the thermometers are giving very low readings because of the cold. Any ideas how to go about this? Just anecdotally, I believe that they give low readings when you're standing in the cold, and that those readings become quite accurate if you're just able to step inside. So it seems to me that just having a place immediately indoors, and the person being screened might appreciate, if it gets really cold, being screened in a safe indoor location where they have not sort of fully entered the DC Health folks might refer to this as a treatment area in a home, but where they've not really fully entered the home yet, so that they can be screened before they really come in. But if someone from DC Health could speak to how you get an accurate temperature reading without using an oral thermometer for someone.
Thank you, Director Reese. This is Daryl Hawkins from DC Health. I think your suggestion is correct. For no-touch thermometers, it's going to be really difficult to get an accurate reading if you're standing outdoors and it's winter time. I think it is appropriate for individuals to be able to step inside the home as long as there are no person-supported or other individuals within 6 feet of that entryway. I think that's appropriate. And additionally, DC Health does not necessarily say that you must use no-touch thermometers. There are other temporal thermometers, as long as you appropriately clean and disinfect it, that's also appropriate. And we do suggest having a backup thermometer in case your thermometer is giving readings that don't make sense. And then if any of my other colleagues from DC Health want to chime in, I think maybe they might have addressed this while I was away, but that's all. And Director Reese, I echo what you also already mentioned. Thank you.
Hi, this is Nelson. I think we talked about this last week. I think this is one of those operational questions. And you kind of need to do what's necessary to get an accurate reading for the method in which you're taking the temperature. So if you know that you're using a touchless system and it's not giving an accurate reading, then you either need to modify the environment that you're testing it in or use a different method, which is what I think Daryl was speaking to.
So someone has a question, will providers have to show evidence that they have encouraged a person supported to get the vaccine, as well as that they have encouraged their staff to do so? We will certainly be following up in terms of the people we support and whether all of them have received a vaccination. So evidence that it's been encouraged, there will be conversations in instances where it's not being administered. It is my, I'll defer to Winslow after I've already said that, but I'll defer to Winslow about the steps that health and wellness will take. In terms of the staff, I think as we move forward, that'll just be sort of an ongoing discussion we're going to need to have as we see kind of the percentage of staff that are, you know, interested in being vaccinated, and the extent to which that does begin to create an issue of risk for the people we support or for your other staff. And Winslow, maybe you could speak to steps health and wellness will take regarding each of the people that they're assigned to.
So health and wellness pre-public health emergency did monitor immunizations that were recommended and or required by primary care physicians and recommendations from the CDC. So what we would do is we would establish likely a tracking system to know of those supporters who has had the vaccine. And I don't believe we would be tracking staff in health and wellness, but it would be prudent to know who has received the vaccine. And so we will be tracking that.
So there's a question here, and I know, Winslow, you were talking to DC Health about vaccines this week. In preparation for immunization program, DC Health asked for provider agreement. Will this be used for distribution of vaccinations?
So in speaking to DC Health on this issue, as many of you may have read or seen in news reports, the initial vaccine requires refrigeration. I believe it's like 80 degrees below zero. So in discussion with the nurse who's on the committee, the vaccine committee, the initial doses will likely be distributed in facilities such as locations designated. And I believe that will be the designated hospitals who have the capacity to store the vaccine correctly. And I don't know if Ms. Stringfield is on the line, but if she is, then if we can unmute her, she probably could speak to it a little more cogently than I can. Is Karen Stringfield on the line? She's probably not. Okay.
We may want to, if it's possible, invite her for next week if that's something she's able to do.
Yeah. I know they're doing field visits, so she may be out in the community.
And as a reminder to people have typed it in the chat box, but when you do the drop down, if you're typing in a question, to everyone is down on the list a little bit. When you first open up the drop box, you may see all attendees and think you've sent it to everyone. Oh, wonderful. Karen Stringfield she says she's in the chat. So if people do have questions.
I am trying to move her over, Director Reese.
Wonderful. Thank you.
It's not really allowing me to do it, but I'm doing my best. Okay, Karen, you should be good to talk now.
Hi, this is Karen. sorry, I was unable to unmute for a while. Winslow, you do have it correct. The initial doses that will be distributed will be ones that require the ultra cold storage. So due to just the unstable nature of it, those will have to be stored in facilities that have the capacity to have that ultra cold storage so that the vaccine will be stored correctly. I'm sorry if I missed another question related to the vaccine.
Well, were just asking a couple of things. One about, given the low number of vaccines that we will be receiving, what impact might that have on the number of on the people supported by DDA, both the people supported and the staff who work with them in terms of where they will fit in priority for getting a vaccine?
Well, our plan is to still, within that phase 1A, to be able to administer the vaccine to all the healthcare providers, including those DSPs who are unlicensed in the congregate settings, to make sure that both the employees and the clients or persons are vaccinated. It's not a one-stop shop, so the vaccine will keep coming, even though our initial supply is very limited. But we want to ensure people that they are going to be accounted for, and we do want to make sure that everybody is vaccinated. It may not be in the first week that the vaccine is out, but we do plan on the subsequent shipments to the various pharmacies to make sure that everybody is accounted for.
So when you say in congregate settings, at DDA, we have people in intermediate care facilities, which are clearly congregate settings, residential habilitation, which are slightly smaller congregate settings, but then we have people who are in supported living, and we have people who are living in their natural homes. Living in your natural home, not a congregate setting, but level of risk may be the same. So who all in those four categories is, sorry to put you on the spot.
No worries. So in our meetings, we do plan for initially the ICF, the clients and the staff. The whole team is aware of what we call our CRFs, I think you call them ResHabs, right?
Right.
Okay, so the CRS, they are aware that there are congregate settings and also staff that are in those facilities as well. We have pretty much outlined all the staff in both of those, in the CRFs and in the ICFs. For supportive living, there is a little bit of complication in just basically getting the number of people, the staff that's going in and out, and also in their natural homes. One is that we want to make sure that staff and clients, hopefully maybe they can be vaccinated together. So if you think about just being able to get around to the different facilities and things like that, the logistics of working out the different locations with a limited supply, we do have to make some prioritization. So that's why for right now, we're focusing more on the ICFs and the CRFs, not to leave out those in the other settings, but just to make sure that we are kind of creating a framework so that we can build a plan so that everybody at some point will get vaccinated.
And there's a question, DSPs, it says, will they get vaccinated where they live or where they work? And my understanding it's based on where they work, correct? Our plan for DC Health, for the COVID vaccine task force, our plan is to actually base our numbers on the workforce. We understand that there are so many people that are working in DC that are not necessarily residents. And that's why DC is so unique, because it's not just
just not just for healthcare, it's for people that work in government, for people that work in all types of settings. So even though we plan for vaccinating the workforce in addition to the residents and the patients and the clients, that is still our plan going forward. And that's why we had to make some modifications with just the distribution because of the low number of doses that we will get initially. But again, the plan is to make sure that each person that lives and works in DC, especially in those ICFs and CRFs, will be accounted for with the vaccine.
Next, there's a question, and I'm not sure who can answer it, regarding CRISP. What part of a person's identification is used to trigger CRISP notification? Some COVID testing sites don't ask for a Medicaid number or a full Social Security number.
So I answered this question privately, but it may benefit others to know that DDS gets daily reports to include Saturday and Sunday of CRISP reports. And the CRISP report just has the person's name, the person's address, and the provider, their telephone number, and I'm looking at it right now. It does not require a Medicaid number. It does not require a Social Security number.
If I could add to that, Winslow, so everyone that we support is automatically matched into the CRISP database, and so that's how the records are matched. So as long as they give their name, address, or anything that Winslow just said, it's automatically linked to us. So everyone that we support is matched in CRISP.
Depending on when the healthcare provider enters it.
Yes. Yeah.
Because it is an evolving system, it seems to me. I mean, different health systems have more real-time reports in CRISP.
I'm sorry, there's a question. What is CRISP? And I do apologize.
Oh, sorry.
The CRISP is the Chesapeake Regional Information System, and it's a health, Morgan typed it in, and I'm kind of ad-libbing off of her answer, but essentially what CRISP allows healthcare workers and now DDA to be able to look into a medical database of real-time records, diagnostic procedures, and documentation of people's experience in ER and while they're hospitalized. So essentially, if one of the people we support goes into the hospital and we need to know real-time information, we found that in natural homes, people were going to the hospital and the family would not let us know. We did actually have someone who went into the hospital in May. The service coordinators had monthly contact with the family, and it took over a month for us to know that that person was in the hospital and actually had expired, because families are educated on the need to communicate with us, but there are times when they don't.
There's a question here, and I don't know if anyone's able to respond to this. Can you speak to allergic reactions that people have had? I know we've heard this in the news recently regarding the vaccine. And I don't know if we have anyone who has that expertise. This is why I'm saying the public information about the vaccine trials came out yesterday. And so, as the informed consents are being developed, there's information to account. So people are learning right now. But I don't think any of this is to jump in. For the vaccines, will they come to the home? I think what we said is that no, there'll be a place identified, but Karen, perhaps you could address that.
as Karen is coming to, it should be noted, so everyone on the call knows that DDA does have settings that are in the state of Maryland, and we will not be able to administer the vaccine to people who live in Maryland. So at this time, there is no plan for them to receive complete parts of the allocation that is coming to us. So we are working out how that will, likely they will be eligible to receive the vaccine in the state of Maryland where they're living. But that's in the forefront of discussions we're having. And there's a question of how will people supported by DDS and their staff be treated with regard to the vaccine. Just as was stated before, they are going to be prioritized based on living in settings that are licensed, and we're working diligently to ensure that people in supported living settings are included in that initial distribution, and their staff will be considered frontline workers.
Well, they're considered healthcare workers, right? Because they're in like category 1A.
I'm sorry, not frontline, but healthcare, yes.
And that leads into the next question, which says, when should staff working in the day program setting expect to get the vaccine? And I would expect they will be with that later group that includes, you know, the kinds of essential workers who come in contact with people. You know, the breakdown has not been to that degree, although Karen may, if Karen's available, she could tell us whether day program, like adult day folks are considered in where they're considered. Based on my recollection, I thought they were like 1B, but.
Yeah, I believe you're correct, Director Reese, based on the chart that I saw yesterday.
So once the vaccine is taken out of cold storage, how long do we have to give it? I don't think that we will be giving it. So from what I heard Karen saying, and unfortunately it seems there's some connection issues right now for her. From what I heard her saying, and Winslow, correct me if I'm wrong, because I know you and she have been talking a lot this week, there will be locations identified with the Pfizer vaccine where people will go to get the vaccine, correct?
That is correct.
Because this issue of it having to be in cold storage.
Correct.
Karen, you are unmuted. So I think it's just something on your end with your microphone.
Yeah, WebEx is becoming my least favorite of platforms.
Karen's response is that there's a plan later on to be partnering with pharmacies to administer the vaccine. Thanks, Karen.
Ah. So Karen says, hopefully clients and staff will be vaccinated in the facility. So you mean that hopefully someone will go to the facility with vaccine, or how would that work exactly? Yes, there will be someone who will go to the facility with vaccine. So I assume that plan to partner facilities with pharmacies will then facilitate that ability to send someone to a facility. Hopefully the exactly is timed with what I just said. So, so here's a person who plans to, and I'm going to defer, please, to DC Health on this. Someone plans to have their son over for Christmas for a couple of days. He lives in a supported living placement with 2 other people. What is the protocol before he comes, while he's here, and when he returns?
I think Daryl stepped off. Can you say that one more time, Director Reese? I apologize.
Yeah, so someone is in a supported living placement, which is shared living. He lives with 2 roommates and there's staff there. And he's planning to spend Christmas with his family. His placement is here in DC. His family is here in DC or the close-in suburbs. So we don't have a travel issue. What would be the best protocol for before he goes, when he's there, and when he returns to the placement?
I would hope that the plan is one that is solid in terms of ensuring that the family understands the necessity to practice good mitigation strategies within their home, to include understanding that their loved one lives with people who likely may be vulnerable. I think it should be based off of the recommendation of the primary care physician for that person. And I'm saying that because I don't know much about the person, and I also don't know the vulnerabilities of the roommates. But as long as people are practicing good hand hygiene, socially staying socially distanced, and wearing the appropriate mask in appropriate settings to meet the staff, I think the plan just has to be thoughtful. I don't expect that the person would need to quarantine and isolate if that's the genesis for the question when they come back. But I will defer to DC Health on that.
So I'm not sure that we have quite enough information from what you've said, as was just stated, to make an accurate recommendation on that. If that person, whoever asked that question, wants to connect with us offline, we can do that. But what I will say is, we are definitely not encouraging folks to go and spend time with those outside of their own household for the holidays. So, if this person is going to their family's house who they do not live with, that's definitely something that is not necessarily recommended. And very careful, stringent mitigation techniques need to be used to make sure that when that individual returns to their home, that everyone is safe and protected. And so I think the best thing is is just a very specific question. I think if they want to reach out to either Daryl or myself offline, we'll be happy to discuss some more details and then come up with a solid recommendation for that question.
Because I'd also be curious currently whether there's visitation occurring already and what kinds of measures are being taken. So I'm jumping off now because I need to go to another meeting, but clearly you all are in good hands and the folks here will answer any subsequent questions. I'll talk with everyone next week and have a good weekend, everyone.
So Nelson, could you put your contact information in the chat box if you would? There's a question, will
Sure.
people be required to quarantine after vaccination for monitoring, or is it just the specified 15 minutes observation that will be required? And that is a very good question. Have not received any information on the vaccine with regard to the administration and post monitoring. I don't believe you would need to quarantine, but I will again defer to my colleagues at DC Health on that one, because I believe they would likely have the more current knowledge on that vaccine as it is new and its requirement at post administration. But then I don't know if Karen's still on the line to be able to answer that question. And if she is, she'd probably be chatting, so I'll go to the next one. So is Mr. Winslow saying DDA funded people living in Maryland will not be counted on the allocation? That is exactly the answer. And that came to me from speaking with the DC Health staff who are on the committee supporting this vaccine effort. Interesting point of reference is that, 95% of all registered nurses who practice in the District of Columbia actually live in Maryland and Virginia, and they will be receiving vaccines that will be administered to them out of the District of Columbia allocation, as well as likely most of the staff, the DSPs, who work with people who reside in the district that we support will be receiving a vaccine in the District of Columbia. So it is sort of a tricky kind of balance. We have people that we support that live in another state that I think is going to be getting about 300,000 doses, and those people, because of their location, will be eligible for those vaccines from what my understanding is, and people who live in the state but work in the district will be getting District of Columbia allocated vaccinations. And those are decisions that are above my scope and authority, I think. But I know I was on a call with health directors around the country who support people living with ID, and this is not common just to the District of Columbia, because many states border and people who live in one state work in another state. So there are serious discussions about how to manage that, because the district is going to have a significant draw on its allocation, because I don't know if people are aware most of the first responders in the district don't live in the district. As again, I'll say most of the nurses who practice in the district don't live in the district. But we have to ensure that because they serve DC the population within the District of Columbia, that they are in fact getting this vaccine. So. It is about 1 o'clock, and I have to follow Director Reese to the meeting that he's currently hopefully already in. I'll stay for a couple more minutes if people have any questions that I can answer in the next 3 to 5 minutes.
So there's a question in regards to insurances. Will people supported be expected to use their insurance?
From my understanding, this vaccine is going to be free, and I will defer again to my colleagues at DC Health. right, so we have a break in questions. So I will just say, everyone stay safe. Have a great rest of your day. Have a safe weekend. Follow the guidelines to mitigate this vaccine. Stay safe. Goodbye.